Good morning, folks. Good afternoon, good evening, depending on your time zone. This is Prakash Narayan, and this is an ongoing series that we've been having on during the COVID-19 lockdown from ATEA. So just 30 seconds about ATEA before I hand it off to our host for this webinar. So ATEA is a American Tamil Entrepreneurs Association. This is a business-focused, non-profit, 501c3, registered 501c3 membership-based organization fostering entrepreneurship among youth, women, and emerging business professionals. Should mention that ATEA is not just to serve the Tamil community, it's intended to expand to the Indian diaspora. So the focus of ATEA is to create a platform for exchanging business ideas, seeking mentorship, investments, so having a community that will allow people to thrive in an entrepreneurial environment. And the theme of ATEA is link, learn, and lead. So we link, of course, in non-pandemic days by having meetups, regional conferences. ATEA, by the way, has chapters in Silicon Valley, New Jersey, and the Midwest and Chicago, and satellite chapters in multiple cities, including Atlanta, Dallas, Los Angeles, St. Louis, etc. So our goal during this pandemic is to connect people and give them information on several topics. So there is a calendar. If you go to that, you can write that down, bit.ly/ATEA webinar series. And through that calendar, you'll get recordings of previous webinars and you'll get announcements of future webinars. So with that, I'm going to hand it over to our host for this morning, Venky Sadagopan. Venky is currently heading up an organization, and he'll talk about that. And he also was the host of North America's longest running Tamil radio show called Southern Spice. So Venky, please take it away.
Thank you, Prakash. Welcome, everybody. My name is Venky Sadagopan. And as Prakash mentioned, I used to run a radio program for 15 long years, which I just recently stopped, and then brought it on to the newer, social media channels like Facebook Live and Zoom and YouTube. So Southern Spice Tamil Radio, which was on FM and AM frequencies for 15 years, is now moving to online media. And I am also one of the early volunteers of ATEA, the American Tamil Entrepreneurs Association, and I'm based in New Jersey. I've been here for 20 years and made this home. So I am a business consultant. I currently am the CEO for a startup called Vertical, which is a company that provides medical translation services using certified medical professionals with native language knowledge across 52 countries in the world. And we provide them in an Uber model. So that's the USP of Vertical. And I also consult for a cloud migration company out of Silicon Valley called Cloud One, and I help them with business development and strategy. So that's about me. But more important today is the fact that we have all been inundated with information, misinformation, conspiracy theories around COVID-19, right? So here's an opportunity for us to hear from an acclaimed award-winning physician and an eminent infectious disease expert. So let me introduce the two panelists on the call today. Dr. Ragavendra Baliga. He's a professor of internal medicine at the Ohio State University School of Medicine in Columbus. Dr. Baliga has written several world-class books, some published in multiple languages, over 40 book chapters, over 350 articles in professional journals, and has been on the editorial boards of 20 leading journals. He's the recipient of the Gifted Educator Award from the American College of Cardiology. So some of his podcasts have also been downloaded over 7,500 times. So welcome to the show, Dr. Baliga. And the other panelist I have is Dr. Kartik Chandran. He is a professor of microbiology and immunology at the Harold and Muriel Block faculty in virology in Albert Einstein College of Medicine at the Bronx, New York. His research focuses on emerging viruses, including COVID-19. So the Chandran Lab, as it's called at the Einstein, serves to understand this molecular warfare between virus and cell and to apply their learning to the development of antiviral treatments. So recently, he has received a $22 million grant to research coronavirus. So welcome, Kartik. Thanks for taking your time to be on this session today and to educate us on this ongoing COVID-19 situation.
Happy to be on.
Thank you for the introduction.
Pleasure. So we have a lot of questions that have already come to us, and in no particular order, right? I may be jumping.
So wait, Venky, I think Baliga had a brief presentation to go over first. So before we jump into the questions,
why don't we do that? Yep, yeah, absolutely.
So I'm going to share his presentation. Do you see this? Are you seeing the presentation?
We are seeing the earlier one that you used for ATI introduction.
Okay, so let me stop share and share again. How about now?
Yes.
Yeah.
Okay.
Perfect. I think thank you for the introduction. And today's talk will be talking a little detail about COVID, but I think this slide is the most key take-home message. The end of stay-at-home orders doesn't mean the pandemic is over. It means there's room for you in the ICU if someone falls ill. And that's why I think the key message is quarantine and self-isolation are more important. And I'll be talking about this more as we go forward. Next slide, please. So as you all know, initially, it was all about the lungs, but increasingly, we are beginning to better understand the pathophysiology of this. The virus infects the individual. The individual then responds to the virus by an immune reaction. And sometimes it overdoes that. And then you get clots all over the body, which then go to the lung, the liver, the kidneys, the intestines, the brain, the eyes, the nose. So now the belief is it's a lot of clotting. So it's a overheated immune mechanism. The next slide. I want to talk about the masks a little bit because in many states say you have to wear a mask. Mm-hmm. The key is not all masks have viral filters, but the key take home for y'all is, if you have a beard, I would recommend you take it off. All of us physicians are made to do that in the hospital because the mask, the snugger the mask fits around your face, the better the filter it is. And these viral filters have a life, so you can see that that's why we try to we try to recycle the masks after use. And of all the masks, I would just put it in two categories: the N95, which gives the strongest protection, which they actually fitted for your face, and all the other masks are some have viral filters, but they're not as robust for protection. And since you all are entrepreneurs, one key take home is, I think the reason they're not recommending N95 masks for everybody because it's a scarce resource and you want to keep for medical workers who are at the biggest risk. But in an ideal world, everyone should have an N95 mask. So if you all can consider do some 3D printing, because this pandemic is here, at least in my opinion, for another 18 months to 2 years. It may come and go, but just looking at the history of the 1918 flu epidemic, it had 3 cycles to it, and we need to be prepared for such a situation. And the next slide, please. So this is a rather busy slide, but I thought I'll share this with you because a lot of information about testing, and Dr. Chandran, who's here, has developed his own test, so he can give us a better overview. But clearly, there are two types of tests. One is the swab test, where they swab your back of your nose and the saliva, where they use PCR to detect the virus. And then there is the immune test. One is an antibody test and one is an antigen test. And if you look at the timeline here, it varies from person to person. It varies from test to test. And you'll see that the PCR tests are initially they go up, and then with time by week 5, week 6, you might not detect the virus. Having said that, it's a new virus. We are still learning. I had a colleague, a cardiologist in Naples, Italy, who I've been kept in touch with WhatsApp. He had full-blown COVID. He didn't have a ventilator, but he needed 8 liters of oxygen. He's back. He's back to normal now, and he's got the antibodies. The two main types of antibodies are IgM and IgG. He's got the IgG antibody, but he's still shedding the virus on the PCR. So his hospital has kept him in quarantine so he doesn't infect his family for another week or so. And so if you see this kind of the nasopharyngeal swab line, which is a sort of bluish green line, it takes at least 5 to 6 weeks to come down, as we know the data today. But as you see, this was published in JAMA on May 6th, so it's hot off the press. And the antibody test, the IgM comes up first and then goes down quickly. And the IgG is the more lasting one. And we're still trying to figure out what titer is protective. And by protective, I mean gives you immunity. And for some people, it takes a while for a while to kick in. And so it's kind of work in progress how all these tests mean. But clearly, there are two types of tests. One is isolating the virus, and the second one is the immune response. So with that, I kind of stop. And my only thing is, we spend a lot of time washing our hands and being a germaphobe. But the key warning is, even if you wear a mask, it's more important to do the social distancing. Just because you're wearing the mask doesn't mean you get too close, because these masks are not perfect, and they may not have viral filters which are endearing. So with that, I'll stop and we can open up for Q&A.
Right, so folks, we have people who've submitted questions ahead of time, so and Venky has those. Once those questions are done, if there's time, then we'll open it up for questions here. Go ahead, Venky.
All right, thank you. Yeah, so the first question that I received was fairly medical one. Can colchicine be given in COVID patients empirically on first suspicion of infection? Or do we need to do certain tests to see if there is a cytokine storm before we start the medication?
That's a great question. And I did a podcast on colchicine because, one of the manifestations of the infection is immune response. And in the US, we have biologics which are pretty sophisticated, like tocilizumab, or complement inhibitors like eculizumab, and several other JAK inhibitors and other which stop the immune response. But I was talking to my a senior nephrologist, my classmate from medical school, who's in Dar es Salaam, Tanzania, and they can't afford the biologics. They don't have access to it. So they use colchicine. And so I was discussing with him, and he said the reason they use it is it's used in a lot of inflammatory conditions like gout and other kind of rheumatological diseases, familial Mediterranean fever. So he uses colchicine. He hasn't lost a single patient, though he has 20 patients with COVID on dialysis. So to answer your question, we don't know the timing of it, but it looks like a week from onset of symptoms is when the when the lungs get involved. And so you don't want to start it too soon because, it's benefit risk. But if you're steadily getting worse over the days, maybe third, fourth day, that's probably the time to start it. But of course, like everything in COVID, this is all empirical. We don't have any data to support it.
Are you aware of any, this is Kartik actually, are you aware of any clinical trials for colchicine that are ongoing?
Yeah, actually,
NYU,
NYU, UCSF,
okay.
and Montreal Heart Hospital are doing it because they found colchicine. There was a New England Journal paper on acute myocardial infarction where it was found to be beneficial in addition to the ones I already mentioned. So it's called the Call Corona trial. Okay, and then there's another study from Europe called the Greek trial. I forget the expansion, the acronym. So when he said that, out of curiosity, I went to clinicaltrials.gov to see if whether colchicine is being studied. There are already 10 people are registered to study it. Okay, and so, but I think this is a big consortium, NYU, UCSF. They hope to enroll 10,000 patients over the next 2 years. So I hope it works because it's kind of affordable in low and middle income countries.
Okay. All right, I'll go to the next question. So there was an article published by Reuters recently on a report by the US intelligence agency that confirmed that the virus was not man-made. Yet the US president tweeted soon afterwards that he believes otherwise. So he wouldn't provide details on his rationale for refuting the intelligence agencies. Opinions?
Yeah, I can give my opinion. When politicians speak, there's a campaign going on. In my opinion, the ratings are going down, the poll numbers are going down, so they create a bogey, but who knows,
I mean, there's no way to really address this scientifically. Well, I mean, looking at the sequence of the virus, right, there's no obvious scar or anything genetically that would say, hey, this is a man-made virus, so, it is similar to other viruses that in this group, including some other bat-like coronaviruses that people have identified that have trapped from bats. So those are real viruses out there in nature. And there are similarities, that are completely consistent with this being a naturally occurring virus. That said,
who knows?
An absence of evidence is an evidence of absence, as they say. And it's, the problem is that, you can envision all kinds of scenarios, right? Like you could envision that some research lab isolated this virus and started working with it. And then from a bat or whatever, or from a pangolin or who the hell knows. And then once you started working with it and they started growing it in cells in the lab, it maybe, somebody picked it up and, we know that it's highly transmissible. So maybe it was a screw up and somebody spread it. I mean, it's certainly not impossible. I mean, this has happened before. If there was this there was this influenza pandemic that was basically almost certainly created because there was a botched vaccination trial in Russia or China on the border someplace on soldiers, and the virus got out. And, in the intervening 60 or 70 years, people had lost pre-existing immunity. So to this particular virus, so it just jumped, so anything is possible, but I guess, I don't think it's a useful, I mean, unless you like conspiracy theories, I'm not sure it's a useful way to spend your time because there's absolutely no way to know. And I completely agree with Dr. Baliga. I mean, there's obviously, Trump is highly interested in deflecting, blame from his administration's completely ineffectual response to this pandemic. And, we know that that's his playbook, and yet the media falls for it every single time. I don't really understand why. But I guess it sells newspapers too. So, and
it's about ratings.
It's all about clicks, it sells clicks. So, I think it's stupid to waste your time on this because there's no way for you to know unless you work in the intelligence community.
All right. Okay, so the next question is on this call with whoever has participated. There is just purely by ATR's organization, there's a bunch of IT professionals, right, ranging from data scientists to AI engineers. How can they help the medical professionals, the doctors and scientists in combating COVID? In other words, what is in your wish list? If you were a pioneer to the, if you were to pioneer a solution to this crisis, like if I had X, I would do Y. What would you?
That's a great question, and this is a new pandemic, and there's so many unknowns. Okay, and I think it's affected the whole globe or the whole planet, so as to speak. And we still don't have answers. Like we started in December, and now we are into May, and we still don't have answers. And so if I was an IT professional who's kind of on his fourth company and made his fortune and wants to give back to the society, I was thinking was to go to, say, a place like India or some lower and middle income countries and create a data. It's all about big data. Create a data lake and accumulate all that knowledge. And then so far, the AI tools have not been all that promising. Part of it is because AI, for example, for a chest X-ray, it's very good at looking at snapshots. Mm-hmm. But the way this condition is, it evolves. So it's more like a video, you know what I mean? So the lung lesion will go from, say, bottom of the lung to the top of the lung, and AI can't handle that. AI can handle bottom. If it's bottom, it is this. If it is middle, it's this. If it's top, it's this. But it can handle an evolution as yet, at least in my opinion about the competency of AI in, say, medical diagnostics. But this may be an opportunity if you have a data lake, say, for example, in diagnostics, in contact tracing, and the AI may be able to give us a big picture view, which may actually be a good tool for us to risk stratify better.
Kartik?
Yeah, I mean, I think that's a pretty good thought. I mean, I think one concern always with these kind of things is privacy. So, can we think outside the box on how to aggregate and use this kind of data? Meaning, one thing, of course, is to anonymize everything, but that needs to be done and needs to be done carefully. But for things like contact tracing, the nature of contact tracing is that it can't be anonymous. I mean, you're talking about individuals. So, in Korea and other countries, Korea is a sort of very technologically advanced country. They were using, in Singapore as well, they were using cell phones as ways to facilitate databases of individuals that had contracted the infection, were diagnosed positive, and their contacts. And this is a way to allow people to avoid contact with other people who had contacts with people who are positive. So, but it comes at the expense of privacy. So how can we do this in such a way as to make that sort of information available, but not do it at the expense of people's privacy? I don't know, maybe it's not possible, but can we come up with ways for folks that really think about these things to develop better tools that will allow us to know where there are hotspots of infection so we can avoid them? Maybe it doesn't have to be at the level of the individual. Maybe it can be at the level of a building, right? But anyway, but can you do this? We already know, although the IT, that the power of the internet and these technologic tools is great. There are, with all due respect to people in IT, they're not always thinking about and it's hard to think about the unanticipated consequences of some of the things that are built, like Facebook is a good example, right? So if we go down this road with COVID, we're going to have unintended consequences. So, we need people to be thinking about that too. But, so we need somebody to a group of people that take a holistic view on this and not just think about this as a way to monetize a business, but which is certainly, and we don't want to discourage entrepreneurialism, but at the same time, can we do this in a way that doesn't hurt people and actually helps the response? So
Great. Thank you. Thank you for that. So I'm moving on to the next one. It's a good question here. There is word from autopsies performed on patients that died from COVID that the deaths are not from pneumonia. So while it was originally thought that the surface of attack was, the lungs, and hence the mad dash to get respirators, it turns out that the patients died from intravascular coagulation, thrombosis. So have we been treating patients incorrectly? Could we have saved lives by treating them differently?
That's a great question, and we are learning as we go along. I think very early there was a paper in the Lancet from China, which they recognized this, and what they did is they looked at something called a D dimer, which predicts clot, so to speak. Not thrombosis, the word used by the person who asked the question. And so they have started these patients on blood thinners. So in fact, in here in the West and everywhere else, if your D dimer was elevated, you got blood thinners. So it's not true that they've not been treating them with blood thinners. In fact, it's kind of anyone with COVID on the 4th, 5th day, if they're in the hospital, it's a part of the cocktail of medications they get. One is a blood thinner.
I'll be back in a second.
They get antiviral medications. And then if there's a sign that inflammation is there, then they get medications to stop inflammation. So the medical community has looked at, has done this. In fact, I would argue that of all the treatments, we are pretty sure work we are really certain that the blood thinners are an important part of the therapy.
Okay. So, so I'll move to the next question. This is a two-part question from Subbu Parmeshwaran. So some of us will be traveling in domestic and international flights in the near future. What do you recommend as a standing operating protocol for us as passengers, apart from just the use of masks and sanitizers? That's one part. The second part of the question is the N95 masks are in a huge shortage. Do surgical masks offer sufficient protection if we were on an airplane?
They are great questions. My first response to the question about traveling is don't. Okay. And in fact, here at the Children's Hospital here, I talked to one of the doctors in here. We have a big 1,000-bed children's hospital. And there, all the doctors have been told not to travel till December. And if they choose to travel anyway because of whatever issues, when they come back, they have to self-isolate for 2 weeks without pay. Okay, because they're really discouraging people from traveling. Not because of this pandemic, we don't know the next wave which is going to come. And knowing from our 1918 experience, there were 3 waves. So this pandemic is here with our lives for the next 2 years. Okay. So then the next point in traveling is the mask. That's again, I want to say the mask is not protecting you. The social distancing is. And don't think because you're wearing the mask, you're being protected. Okay, unless you're wearing an N95 mask. And you can't wear an N95 mask for a long flight. You know what I mean?
Yeah.
So social isolation is going to be the key. So even if you're wearing a mask, you want to keep at least 6 foot away from the next individual, as much as you can. But I was reading a report, Heathrow and all are struggling about social distancing. To prevent infection, there are only 3 ways to do it: social distancing, and social distancing. Okay. So now,
I guess we don't really. Yeah. Sorry. Finish and then I'll. Yeah.
Yeah. The N95 mask, you're right, because it's a scarce PPE. The surgical mask has a viral filter, but it really doesn't fit around your face. What it does is it protects. It sort of sends a signal to the other person to stay away from you because they don't know whether you're recovering from COVID or you have early COVID. It just sends a signal in my mind, And And of course, Kartik is using it in his lab, so he'll have more insights.
I mean, I just think we don't have a lot of data actually on, I mean, I guess, definitely agree that, it's a signal for social distancing, and it's fun. You can do this experiment when you go out on the street. If you don't wear a mask, often people will cross the street actually. So in a way, not wearing a mask is providing a signal for social distancing. If people think you're a crazy person or irresponsible. But I mean, again, we don't have hard data. I think that's totally right on the effectiveness of like surgical masks or even these homemade masks that a lot of people are wearing now, or even like a scarf over your face. I mean, but physics dictates that it's got to help. I mean, it's not going to be 100%, but I'm sure it does something. And you have two people wearing masks that are cohabiting in the same space. It's a multiplicative effect from the person that's shedding and the person that could be receiving it, the inhaling virus in breath, for example. So, totally agree that it's definitely not guarantee of anything. But I mean, again, we don't have a lot of studies, but, and it's hard to study this, on a population level. But I mean, you should cover your face. I mean, in some places you have to do it, like in New York. Yeah, I don't know. I mean, and absolutely social distancing is a big part of this. Surfaces are a big source of virus as far as we know. So being really cautious about hand hygiene, I think the slide is up, you can see it. So that all makes sense. I don't know how we really move forward because I think it'll help to have countermeasures that we know work, so that, that will give people some degree of confidence that even if they do contract the infection, they develop a serious course that something can be done. I think ultimately the vaccine is going to be the key, and we're at least 6 months out, I think, at this point. So I think it's really hard. I mean, psychologically, even for people that like me that work at a medical school, I have half my group working in lab wearing masks, and they are wearing N95s actually, because they're doing some procedures with COVID samples, but they're not wearing N95s all the time. It's actually hard to breathe through an N95 if it's well fitted, and that's the point. But the rest, about half my lab is sitting at home and wants to come back to work. They want to know when they can come back to work. They want to know. So we've developed our own antibody tests that our hospital will be running, and we've already tested some people in my lab unofficially, and some of them are positive, some of them are negative. It's not entirely clear, as we were discussing earlier, what that actually means in terms of long-term protection. Especially, I think if somebody has a strong antibody response, you can feel confident. Well, first of all, if you have an antibody response, you were exposed, and if you didn't develop serious disease, it probably means you won't again. But it's, that's a reasonable assumption. But what if you're borderline? What if you had no symptoms and you just have a borderline response? Then we can't even really know if you were exposed or not. So there are a lot of challenges, and I think we're going to need to do a lot of workplace studies actually. And I think unavoidably we will be experimenting on the human population, because there's no other way to figure this out. We're going to start letting people out. It'll happen at various levels. Like, for example, we're writing a protocol to essentially do this, at my hospital, to allow people to come back to work with social distancing, with PPE, maybe with shifts. And then we monitor them, we recruit them with consent into a research study, and we monitor them longitudinally. We take their medical history, we look at their swabs, we look at antibody tests, and we do this, once a week, and we see, we swab them every week, we take blood every week, and then, we have them monitor temperature, all that stuff. And then, this will happen all over the place. And in a few months, I think we'll start to get some more granular data about what's protective and what's not protective. But until that happens, we're not going to know. And until that happens, what Dr. Baliga says makes complete sense. Avoid getting on a plane. I mean, what do you have to do? I mean, if you, there's a lot of things you can do remotely, do over Zoom meetings and things like that. But, there's just absolutely no way to be absolutely sure that you'll be protected. So,
well, yeah. So at this point in time, the Indian consulates are actually collecting data and names of passengers who want to travel to India for any sort of emergency situations. Like, for example, a lot of people who visited US or who are here on other type of visas, non-OCI people who have any kind of family emergency situations in India
Mhm.
are getting ready to board certain flights. There are flights going out of New York and Chicago and San Francisco and various places, and they are building a list of names of passengers to go there. And one of the things they have said is on arrival in India, you will have to self-quarantine for 14 days. And they will enforce it in some form or fashion. But these,
Yeah, but I mean, yeah, this is like, I don't know. So they do that, but then they go out into the community and they get it from somebody else. It's not like there's not infection in India. If anything, the rate is increasing. So it's sort of pointless, really. I mean,
yeah, it
it's
is a
fine.
risk that they're running, even if they're going to be, availing of this facility to travel. Even though there is an emergency situation that they have to be there, but it's better and safer for them not just to stay put and not travel. Is that right?
Yeah, it would be.
Yeah.
I mean, I'm not actually worried about the plane. They filter the air.
Mhm.
They have HEPA filtration on the plane. It's the airport and being close to a bunch of people. But if they're doing social distancing at the airport, then maybe that's not an issue. But once you land in India, and they're already relaxing the restrictions on movements of people are already starting to collect and aggregate in large groups. I mean, I guess I would be more concerned about their exposure there than here.
Okay. Or
But
even on the flight, right? If there are passengers sitting next to each other, even if it's one seat apart, it's still not.
But a lot of these planes are flying empty, right? I mean, they're like, the average occupancy on these flights is like 14 or something. I mean, I don't know about these flights to India, but certainly domestic flights are flying largely empty. So I don't think it'll be difficult to arrange a situation on the flight where you can practice some level of social distancing. I don't think they're going to be packing people like sardines for quite some time to come on planes anymore. I don't know if anybody's flown recently. I haven't, but I'm that's my understanding of the situation. So I'm actually not, for these folks that have to go home for emergencies, I'm not so worried about that. I think it's really more about, you just don't know who's infected where, and anytime you interact with other people, you could pick up the infection.
Okay.
And I think if anything, of all the industries, I think the IT industry should lead the country by having Zoom meetings rather than travel, because you all are well positioned to do so,
Sure.
unlike other.
But if you have a family emergency, you've got to do what you got to do.
Different issue, yeah, that's a different issue.
So,
But I'm saying for meetings, for business meetings or whatever,
right.
All right.
Avoidable travel should be avoided.
Sure. All right, I'll move on to the next question. I have to keep an eye on the time as well. We have 20 minutes. So this is a question from Janki Anand. If one can be asymptomatic carrier of COVID-19, then would that person have antibodies? And by extension, does COVID-19 negative test mean that I may never have been an asymptomatic carrier?
I can answer. So it's a really good and important question. So could you just repeat the first part again? There's two pieces and I'll take it.
Yes. So if one can be an asymptomatic carrier of COVID-19, then would that person have antibodies?
Yeah, we don't know. So the reality is we've actually, and a lot of people are doing this, we've surveyed 300 people that had mild infections. So these are people that didn't go to the hospital. Most of them had positive swab tests for the virus. And even in this cohort, about 10 to 15% of these people have no detectable antibodies. So it depends on what you mean by asymptomatic, right? Do you mean just a sniffle? I mean, just like a little bit of a sore throat, a little bit of a runny nose. So I have somebody in my lab who had incredibly mild symptoms. Under normal circumstances, she wouldn't have cared, noticed. She was, swab positive and developed a reasonable IgG titer in a few weeks. So I think the bottom line is that, I don't have a satisfying answer for this, but I would say that if you have, and it's really semantic, what do you mean by asymptomatic, right? Like it maybe that symptoms are so mild, you don't really notice them or pay any attention. And so if you sort of put that into a spectrum, those people, some of them will develop antibody responses some of them won't. I think those individuals are probably fine, right? Because, you know, if they were exposed and were infected and they developed a mild disease or no disease, they probably will have the same thing the next time, right? Unless there's something weird about this virus that we don't fully understand yet, which is possible, right? Like sometimes people don't develop, like with dengue, for example, people will have a mild course, and then if they get infected with a different serotype of dengue, they can develop really severe disease. There's no evidence, despite all the stuff about strains and all that, it's all mostly not there's no evidence that this virus has evolved into these different clades that are really quite different immunologically. So I'm not so worried about it yet. It might do in the future though. But there's a second level issue there, which is, you know, there's risk to you and then there's risk to other people, right? So if you develop very mild or no symptoms and you don't really develop a strong antibody response, you may still be shedding virus. If you were to get exposed again and the same thing happens again, you may develop mild upper respiratory disease or infection that would allow you to shed. And then that shedded virus could still be, you know, make somebody else really seriously ill. So I think there's sort of like two issues. One is your personal safety. And then the second is the risk that you pose to society at large. And, you know, it's not entirely clear what to do, I mean, about that, you know. So what was the second? I'm sorry, I don't have a satisfying answer, but that is the reality of the situation. We don't really understand what is the antibody course in, you know, in mild or asymptomatically infected people. But I don't think they need to worry in general because they had a mild disease or a mild infection the first time around. There's no reason to think they're going to have a severe infection the second time around, unless, I don't know, it could be. I mean, if they have a comorbidity that develops and then maybe then that's different. But, you know, if it's status quo, all else being equal, probably their second exposure or the subsequent exposures would not be problematic for them. They may even mount a strong antibody response the second time because they're primed from the first exposure. And then what was the second part of the question?
Second part is, does COVID-19 negative test mean that I may never have been an asymptomatic carrier?
No. So if you have a negative swab, so the specificity or the false negative rate on the swab is substantial. Mm-hmm. So as high as 30 to 40%, which means that if you have a positive swab, it's very, very likely that you were exposed. If you have a negative swab, it's not quite 50-50, it's a little bit better than that, but there's a significant possibility that you were exposed. And remember that, as Dr. Baliga talked about earlier, you know, you don't keep shedding, right? So the swab test is a very time-sensitive test, a time-dependent test. So some people can shed RNA, and this is not necessarily infectious virus, by the way, it's just RNA. They can shed RNA from their oral nasal, you know, passages for weeks. But some people most people just stop shedding. So, you know, it also depends on when the test is done. But the bottom line is, as with many tests, a negative doesn't necessarily mean that you weren't exposed. It's just that a positive means that you were exposed. So yeah, if you have no symptoms, you have no antibodies, and you're negative on a swab, that doesn't mean you weren't exposed and didn't develop a very mild or asymptomatic infection.
Okay.
I don't know if Dr. Baliga wants to add something to that.
Yeah,
No, I agree. The trajectory is very, very different. And the flip side is also there. Like I said, I had a friend who had the antibodies, but he was still shedding virus.
Well, I mean, the only thing I would say to qualify that is we don't actually know he was shedding virus. He was shedding viral RNA. So right. So we've actually tried, and we have collaborators that have tried to culture virus from remnant swabs from people that recovered from infection and were still shedding RNA that was still positive in the swabs, even with pretty high CT values or low CT values, i.e. pretty strong signal of RNA being shed, and they could never grow virus out of that sample. So those multiple, like 30, 40.
What about the feces samples, which they said there is?
I would be very, very surprised if anyone is able to grow virus out of feces at any time point. But
because there was a Lancet article which explained it, but described it. But you know, the burden may not be enough to cause.
If there is any, right? Like, so for example, you can detect viral RNA in blood, but every once in a while, it's actually not that often. This is not a bloodborne infection.
Yeah.
That's even no, not as there's not been a single case report or example of anybody successfully culturing virus out of blood. And that's not surprising, right? I mean, we know this from influenza. I mean, you know, for example, like there are other respiratory viruses that really don't cause significant viremia or virus in blood, and they're not in general a risk to the blood supply or anything like that. So, and this virus appears to be in that category.
So, in fact, Venky, there's a related question from Pat Krishnan. So the question has to do with, there's a lot of messages on Ayurvedic supplements, such as Sudarshana Churna, which can fight COVID by increasing immunity. So what are your thoughts and recommendations on this?
Somebody should do a clinical trial, and then we'll see.
We don't know.
Right.
We don't know that's the answer, really. But, you know, but it's an interesting thing. They're saying, people asking me the other question, like, how can we improve our immune status? And the only thing which can come close, and again, we don't know about that too, is they say if you exercise regularly, that could be beneficial. In fact,
also, not being overweight. I mean, I think we already know. I mean, I don't, again, maybe Dr. Baliga, you know, but there's, you know, there's a good reason to think, well, we already know that, you know, being insulin resistant, which a lot of people are, and especially in the Indian subcontinent, even if they don't necessarily aren't obese, technically, they have, if you have a pot belly, that's usually a pretty good, if you're a man, that's usually a pretty good sign that you're developing insulin resistance, because you have all this sort of centripetal fat that, you know, is a sign of, you know, that onset of that sort of process. And we know that that's an inflammatory disease. And there's already some data, although I haven't seen a lot of good data, really showing that people who are type 2 diabetics or have insulin resistance can develop some more severe disease courses. But that would not surprise me at the least. So I feel like, I don't know about the churnam, but if you're overweight, you may want to work on that, because that might be a more significant risk factor than, you know, just in terms of actually mounting too strong of an inflammatory response once you get infected. I don't know if Dr. Baliga, you have something.
Yeah, and you're right. So this data, actually, people who are hypertensive, diabetic, and obese and above the age of 60 are more susceptible, suggesting that it's the immune system is not perfect, no less than perfect. And the only way you can do that is exercise. And in fact, like Kartik said, we're all insulin resistant, you know, the day we are born, in a way, I could argue, compared to the rest of the world. And we really have to exercise. And I would say that exercise is going to be key to develop immunity. For listening to the director of the vaccine center from Mayo Clinic, and one question was asked, how come bats carry the virus and they don't get infected by it? And he argued maybe because they're flying around a lot of time, they're exercising all the time. And
yeah,
so
there's a lot of theories. Bats are weird. They also have, there's a theory, it's really just a theory or hypothesis, that because bats have, bats are like, have a weird metabolism because they fly. And so they always have this elevated body temperature. So a lot of their immunologic sort of, you know, sensors for infection are all kind of reset. They can tolerate higher levels of basal infection without triggering a strong inflammatory response. So we worked on Ebola before all this, and that's another example of a virus that replicates in some bats, but doesn't seem to kill them, but is highly lethal in humans. And part of it seems to be, maybe not with Ebola in particular, but lots of other viruses and other pathogens, is that if you can take like a dose of bacteria and infect it into a human, and they will go into toxic shock and die. But you can put that same dose into, and this is a piece of bacterium called LPS, lipopolysaccharide, we've evolved to recognize, and we're incredibly sensitive to it. But if you put that same amount of LPS into a bat, they don't even get an increase in body temperature, right? They don't even develop a fever. So bats are weird. I mean, there's no question, but bats can also get infected with things. I mean, there's white nose syndrome, which is a fungal infection in bats in North America that's decimating certain bat species, right? So bats have their own unique vulnerabilities because they hibernate and their body temperature drops. During that time, if they develop infections that raise their core temperature, they lose so much energy that they literally starve to death. So there's, bats have their own issues.
Now, do bats get infected by viruses?
They sure do. Yeah, they're bat viruses.
Yeah.
They can get
Which-
infected, they can
which
even
of
get
them?
killed, but there are a lot of viruses that they seem to harbor that
Yeah.
cause relatively mild infections in bats. And so Ebola, for example, so Marburg virus, which is related to Ebola, that's not what this call is about, but if you inject it into a bat, the bat will develop a very transient viremia or virus in blood, but it will actually shed a lot of virus in saliva. And that allows, and juvenile bats bite each other a lot. So this is a way for the virus to transmit in the bat population. That's not what really happens in people, right? Like we get these whopping, insane amounts of virus in the blood everywhere. And so it's also about how our immune system is wired. That's just different. And some of these bat viruses come across and they just, it's like a burglar that's cutting a wire to disable the alarm system in bats. When it does that in humans, it blows up the whole house. So it's, it's a mismatch between like our immune system and the bat immune system. That's a bit of a problem. And this isn't true for all mammals. For example, a lot of bat viruses can infect some other mammals and not have a huge effect. I mean, it's complicated. There are a lot of different reasons for this. Some of it's the immune system, some of it's other things, but anyway.
So folks, I was hoping that we will reach this point. I wanted to unmute so that other people in the call can ask questions as well. So Venky, any more questions from your side, or can we unmute people?
I have a bunch of questions,
Okay.
Prakash, but I'll just ask this one last question before we unmute.
Okay.
So has the novel coronavirus been established as causing agent for the infectious disease? Have all 4 postulates of Koch been applied? Is the question.
What's the first question again?
Has the novel coronavirus been established as causing agent for the infectious disease? And the second part is, have all 4 postulates of Koch been applied?
Yes.
Yes.
Okay.
The answer is yes.
Probably more for this than for most other things.
Yeah.
Okay. All right, Prakash, yeah, let's go ahead and open it up, please.
So people are unmuted. You can, of course, if you're not speaking, please mute. Otherwise, we'll see. If there are more questions coming in, then maybe we'll request Dr. Baliga and Dr. Chandran to extend. But everyone's unmuted now.
Hey, this is Pat. I just have one more question. How many strains of COVID have been isolated so far? And is it like the vaccine that the pharma company is trying to come up with will solve all the strains of COVID?
This is Kartik. This is an important
No,
question.
I just shut it off for now. I need to listen.
Please mute if you're not speaking. Thank you.
This is an important question. So a lot of the current vaccines are being developed against the spike protein, and this is the protein, of course, that often changes the fastest in a lot of viruses. So I think this idea that there are these different strains, I think this is a very new sort of, there's not a whole lot of evidence that, there's a lot of papers coming out, preprints especially, these are not peer reviewed, these are preprints that are just being deposited on the internet, that suggest that the virus is evolving. It's not a surprise, this is an RNA virus, it will mutate. The question is whether these, it will just happen anyway, just as the virus is spreading through the population, it will develop these amino acid changes, these mutations, and you will get these clades and lineages. That doesn't mean that these clades and lineages have different properties. It can be completely stochastic just because these viruses mutate. And the process of spreading an infection from one person to the next is what we would call a bottleneck event, which means that only a very few number of virus particles actually transmit, which means that because these viruses are inherently undergoing a high mutation rate, you're always selecting, when you go into this big bag of viruses and you scoop out a few, all of them are going to be mutants, pretty much. Because just statistically, any given particle of any given RNA of a virus particle is likely to have some changes in it compared to the overall aggregate. Like it's important not to think of viruses like people, right? So if you look at all the people on Earth, and you sequence their genomes, you'll find that, there are differences, right? And so we kind of make, if you think about a genetic space, we make sort of a blob in that space. If we were all genetically identical, if we were all clones, we would be a single point. But because we have some sequence diversity, we're like a blob. Well, if you take a virus population in a single tube in a lab and you do the same analysis, it will make a bigger blob compared to all the humans on Earth. Because viruses, especially RNA viruses, are inherently undergoing mutations. And so as these viruses are spreading, out there in nature, they will inevitably diverge genetically. It doesn't necessarily mean that these different lineages have different functional properties. So with influenza, for example, like one of the issues is that it's an avian, it's a bird virus. And when it jumps into people, a lot of times that infection can't really progress for a variety of reasons of mismatches between the virus and the host. So that process, and the same thing happened with HIV, that process can, every once in a while, you can throw up a mutant that can somehow replicate in the new host, and then it can take off from there. We're not seeing that here, right? So there's this very famous example of a cat virus called feline parvovirus, which underwent a single mutation that allowed it to infect dogs. And then it caused this global pandemic. And then this one virus spread and caused this whole family tree of viruses that were closely related in dogs, right? So that first step required this adaptive mutation, right? There's no evidence that once this virus jumped into people in China, that the virus has required any such adaptive mutation to spread, because it seems to spread just fine the way it is, right? But it's inevitable that as the virus spreads, it's going to mutate. And it's quite possible that at some point we'll get some weird mutant that does 100 times better in humans or something. That's not very likely, but it could happen because the virus is already spreading. You have to think about this as competition. And the competition is really between viruses. It's not about humans at all. So, in order for one virus to sort of outgrow the others, it needs to sort of and take over the world. This is what we call a selective sweep, which happened with this cat virus that turned into a dog virus, for example, right? It has to have some sort of selective advantage that allows it to outcompete all the others, right? And the virus is already pretty well adapted. We're not really seeing a huge, reason for this sort of strong selective process to take hold. So I think we don't have all the data, and what I'm saying could be wrong and might change in a week. But so far, the sort of the genetic diversity we're seeing in this virus seems stochastic. It's just, you're selecting these random variants and then they're expanding and then spreading to other people. You're creating these chains of infection with slightly different mutants, right? There's some evidence maybe for some selection at certain positions in the virus in the sequence, but it doesn't appear to be really adaptive. It seems more like stochastic or random. So given that the totality of the evolution seems stochastic, I think it's unlikely that this will pose trouble for the vaccine. What will be done is when people are immunized with, also the other thing is that when you vaccinate somebody, you get a polyclonal response, which means you make many different antibodies and reactive cells to many different epitopes or sequences in the virus. So this is like gang tackling in football. There's like 10 people jumping on a person who has the ball, right? So even if this virus is able to shake off one of the tacklers, there are 9 other tacklers there, right? So a vaccine is a group attack on the virus. And so that's another reason to think that unless we're like spectacularly unlucky, we're not going to have trouble with the vaccine. It's more of an issue with specific drugs, actually, like antibodies or other drugs that target the virus in a very specific way. So there, even just by accident, you could get a mutation in the virus that protects it. Or you could actually, the drug could create a selective pressure, right? This is what we see with HIV, right? Like, so if we learned in the 80s that when you put somebody on an anti-HIV drug, initially the virus titer drops, but it doesn't go away completely, and then it'll come back because you essentially create a selective environment for a mutation, the mutant that's there at a low frequency to suddenly expand and take over the population, because all of a sudden it's the only one that can grow. All these others can. So it's actually the vaccine that may create such a selective pressure. The worry is that the vaccine is not very good it will skew this viral population towards mutants that can actually grow in the presence of the vaccine. So it's very important that whatever vaccine we deploy be quite effective, right? There's two pieces to that. One, the vaccine's got to be, really good, so it can reduce the infection of the virus. Because if you let the virus, give the virus a little bit of room, it will expand and it will mutate to potentially get around the vaccine. Okay, that's one thing. But the second thing is to vaccinate as many people as possible, because this is a game of numbers, right? So the virus needs people to jump to, right? And if vaccinating people is the equivalent of giving them an N95, you have a bunch of N95, people wearing N95s, the chance that the virus can actually get from one person to the next that's actually susceptible is very, very low. And this is actually why, for example, something like malaria can never catch hold in a climate like in the northern US, because once you reduce the ability of the mosquitoes to transmit the infection below a certain point, it goes to zero. Because it's just math, it's statistics. The probability of successful, people have modeled all these things, and probably there are people on this call that are much better at this than I am thinking about. But the idea is that with a vaccine, if you reduce the number of susceptible people, especially in a cluster, low enough, then even if the vaccine isn't 100% effective, it will still work. But it is important to get the vaccine working as well as possible. And it's a very important thing to think about when you're deploying drugs, because, just like we get antibiotic resistance to drugs in bacteria, we can have antiviral drug resistance as well. But because a vaccine is inherently a polyclonal product, it's inherently a line of attack with multiple points of attack, the hope is that a single mutation in the virus is not going to make the vaccine ineffective, right? It's much more of an issue for much more specifically targeted drug. But that said, this is all completely new. It's ongoing. We are doing our own sequencing here of viruses from patients in the Bronx, and we'll know. And there are already papers out there claiming that there's adaptive evolution happening. I don't really, we haven't really seen the convincing evidence of that yet, but that doesn't mean it's not true. And it certainly doesn't mean that it's not possible, and like 3 months from now, we might be looking at something different. Is it likely? I don't think so. The virus is already spreading so well that any variant that developed would have to be substantially better adapted than the current viruses that are replicating. And it's hard to see how the virus gets that much better in terms of transmission.
Awesome.
So that's a long answer, but yeah.
Any other questions, folks?
There's just one that's come up. No, there's no question. I mean, well, there are a few more questions, but I think, Prakash, we are out of time now, right?
Yeah.
It's already past 1.
Right.
So if necessary, if we collect a bunch of more questions, we may kind of try and do one more session, maybe a week or 2 weeks down the line.
Yeah.
So
Definitely.
yeah, yes. So having said that, I guess we can close this out for today. Thank you so very much, Kartik and Raghavan, for being here and sharing a wealth of knowledge, which we normally won't be able to get anywhere else. This was really, really eye-opening, useful, and truly a great session. Thank you so much for taking your time. And hopefully within the next week or 2, we will do a follow-up session with more questions.
I mean, the one thing I would say is be skeptical of everything, but in an informed way, because we're just, this is new to all of us, right? Like, I'm a virologist. I've been doing this for 25 years, but this is a new thing. And a lot of the questions that were raised, we don't really have good answers to yet. So hopefully
we are learning along the way. Yeah. Thank you. Be safe, everybody.
Thank you. Take care, all of you. Bye.
Thank you. Thanks, Prakash, for the opportunity.
Sure thing. Take care. Bye.
Bye.